Welcome everyone to the Summer Sun and Skin event. Thank you so much for joining us today in today's conversation that will mostly be focused on skin cancer prevention. Um, we look forward to having a really great discussion with our speakers. We have three really great speakers on the call who will be available to answer any questions that you might have. My name is Melissa Martinez, and I am the UIC Outreach Core Manager for Chicago Check. And this event is brought to you by UIC's Department of Dermatology, the University of Illinois Cancer Center, and the Chicago Cancer Health Equity Collaborative, also known as Chicago Check. And so just to go over some ground rules, we're going to ask that you please keep your microphone muted while others are speaking. If you do have a question during the presentations by the speakers, please feel free to type your question in the chat. And then once we open up for discussion and questions for the last 30 to 40 minutes or so of today's conversation, you're welcome to ask the question or raise your hand, and then we'll answer your questions accordingly. So I would like to welcome our speakers now. We have Dr. Maria Sucas. She is an associate professor and she's the head of the Department of Dermatology. She's the director of the University of Illinois Health Clinic, procedural laser and aesthetic surgery, and she is part of a skin cancer collaborative. We also have Dr. Pravin Patel, who is a professor of surgery. He's a chief of the Division of Plastic, Reconstructive, and Cosmetic Surgery in UI Health's Craniofacial Center. And then we also have Dr. Tatiana Dixon. She is an assistant professor of head and neck surgery. She's the residency program director of facial plastic and reconstructive surgery. So I just want to give a warm welcome to our speakers. And now I will turn it over to Dr. Sukas, who will be giving us more information on dermatology.
Good afternoon. Thank you so much for this nice introduction, and thank you so much for having us. My name is Maria Elena Sucas, and I will speak about the skin cancer. I'm trying just to share my screen a little bit. Okay. No, I think I'm sharing. Or probably no.
Yeah, we can see it if you want to put it in presentation mode.
Yes, of course. Okay, great. It's always a little bit of a AV monitoring technique. Thank you very much for having us for this nice event and conversation. Many thanks to Chicago Cancer Health and Equity Collaborative, and also to UI Health Cancer Center for organizing this event. And of course to our participants and our colleagues. So skin cancer is so important to be aware of it, to know about it, and screening makes a big difference. I mean, if we think about it, skin is really exposed and we have access to skin. 1 in 5 Americans will develop skin cancer by the age of 70. More than 2 people die of skin cancer in the US every hour. Having 5 or more sunburns doubles the risk for melanoma. And when detected early, the 5-year survival rate for melanoma is up to 99%. And even, above 95% for other skin cancers. So it's so important to know about it and detect it early. Anyone can get it. And it is important to check it out, because skin cancer will not check itself out. So I will review as far as the precancerous lesions that we see very commonly, the actinic keratosis, the most commonly seen skin cancers like basal cell and squamous cell cancers, malignant melanoma, and Merkel cell carcinoma. And as we see here, the skin has three main layers. One is the epidermis, top layer of multiple layers of cells, and then the dermis and the fat. And as we see here, these cancers are emerging from those cells. So basal cell carcinoma, squamous cell carcinoma, and melanoma. And of course, not to forget that melanoma can be pigmented and not pigmented. So coming to the basal cell skin cancer is the most common skin cancer that we see, with 3.6 million cases diagnosed in the US every year. Skin cancer for basal cell can have several presentations. We can have superficial lesions, which present on the skin as superficial erosions, and sometimes, can be like non-healing little spots. Then it can grow and further expand in the skin and can present as nodular basal cell skin cancer. It can be a pearly kind of nodule with some dilated blood vessels, and at times it can continue to bleed and not to heal. And then we can have infiltrative basal cell skin cancer, where basically the clinical evidence does not show where the histologic margin of the tumor could be in the skin. And in those cases, it invades deeper in the skin. As we see here, it can even create a little dimple in the skin. Basal cell skin cancer can also present with some pigmented variants. So we have pigmented BCC, and we see ethnic skin. So we see that quite a lot, though we see BCCs is even non pigmented skin or ethnic skin. And of course, this skin cancer can expand locally. It tends to expand and really destroy the surrounding tissue and anatomic structures, as we see in those examples. It can be kind of nodular, and also, again, can have some crusting, can be bleeding, and it can also look like a pigmented growth on the skin and can be misdiagnosed as a melanocytic lesion or malignant melanoma. Coming to the second most common skin cancer, squamous cell skin cancer. This is involving about 1.8 million cases diagnosed every year in the US, with 15,000 deaths yearly, twice as melanoma. So squamous cell skin cancer is more serious, because it tends to spread more and also tends to metastasize more than basal cell skin cancer. These lesions present on sun-exposed areas as well, and they can be kind of eroded, crusty, not healing, bleeding, as we see here, on someone's face, on sun-exposed areas, or even on upper extremities. It is important also to ask about if any pain sensation, because sometimes these are invading deeper in the skin and they can invade nerves and they can cause pain to the patient. So it's really important to know about that up front. And also, it can present in areas that have extensive sun damage, as we see here, with really over 2-centimeter areas involved. It can present as little cutaneous horns, and also it can present with some pigment, as we see here, and can be misdiagnosed as a melanocytic lesion. There is also a combination of basal squamous skin cancer. In those cases, we see in the same lesion features of basal cell and squamous cell skin cancer. And in this case, we have an extensive lesion that was removed with wide excision and also reconstructed promptly. Actinic keratosis is a precancerous lesion we see very commonly on sun-exposed areas, and mostly on fair skin type people. It affects about more than 58 million Americans. And here we see how these small, scaly, kind of greedy papules are presenting on skin that has been sun exposed. Sometimes it's even hard to see and we feel them. And this is a transition to superficial squamous cell skin cancer, like SCC inside 2, getting to invasive skin cancer. Some other additional examples of patients who have been fair skin, as we see here, red hair, of course. So those areas have received a lot of sun and present with these small, kind of scaly, greedy little lesions. And it's important to follow and treat these lesions, because there is a chance of transforming to a skin cancer 1 to 10%. When we treat these lesions, we treat them as single, but also we treat the entire area, because in this case, we have the field cancerization concept. This means that if you have certain lesions that are just emerging because of chronic sun exposure, it's very likely that this patient will have some additional lesions coming up in the coming years. And so it is very important to treat these patients, to see them periodically with field cancerization therapies. As we see here, the entire field needs to be treated, not only the single lesions that we detect. And so we prevent in those cases the evolution from the actinic keratosis to aggressive skin cancers, as we see here in this photograph. Malignant melanoma is the deadliest type of skin cancer, so important also to detect very early. In 2021, there is increased 5.8% new cases and 4.8% of deaths. 20 to 30% of melanomas are found in existing moles, and about 70 to 8% arise on apparently normal skin. Between 2011 and 2021, the number of new invasive melanoma cases diagnosed annually increased by 44%. Men of age 49 and under have a higher probability of developing melanoma than any other cancer. Women age 49 and under are more likely to develop melanoma than any other cancer except breast and thyroid cancers. Also, UK study showed that about 86% of melanomas can be attributed to exposure to UV radiation, ultraviolet radiation, and also for stage 1 melanoma. For those patients who are treated within 30 days after being diagnosed with a biopsy, then comparing to those who are treated 30 to 59 days after their biopsy, there is a 5% higher risk of dying from the disease. And those treated more than 119 days after the biopsy, there is 41% higher risk for dying of the disease, which means that once we really figure out about melanoma, this is really a top priority, and there has to be appropriate follow-up and treatment arranged accordingly. As we see here, these lesions present with variations in pigmentation, so darker and lighter, variations of dark brown and black. There can be some areas of whitening in the lesion, which means regression, and it's good really to catch that early and treat it as indicated per protocols. It can be even light pigmentation. And so very, very important to screen the patients periodically for different melanocytic nevi, and if indicated, we need to biopsy promptly. These are cases of neglected melanomas. Obviously, this is very unfortunate to see from our dearest patients. They came in for lesions that they almost never saw before. And on the right side, you see a lesion came into clinic for treatment for a wart. And unfortunately, of course, we biopsied and it was a malignant melanoma, and it was addressed promptly. Now, is it really true? I thought my darker skin would protect me. Not really, because melanomas can also present in ethnic skin, though squamous cell carcinoma is the most common skin cancer in Black people. People of color have higher percentages of acrolentiginal melanoma, and also late-stage melanoma diagnoses are more prevalent among Hispanic and Black people than non-Hispanic white people. 52% of non-Hispanic Black patients and 26% of Hispanic patients receive an initial diagnosis of advanced stage melanoma versus 16% of non-Hispanic white patients. So in those patients, we see melanoma at advanced stages. And again, as we see here, melanoma can present at all different areas, exposed and non-exposed. So that's why it's important to look everywhere, even in between the web toes, the web spaces of the toes. And then we see here one lesion, plantar surface, was treated with graft repair. Again, with a lot of variants, with different darker pigmentation and lighter pigmentation, areas of whitening, areas of what we call kind of duskiness or blue veil as we describe it. It can also present on sun-exposed skin. It can present around areas, around the nails, there's some subungual areas. So very important just to follow very closely, look closely and detect them. Merkel cell carcinoma is a rare aggressive form of skin cancer, and it's been increased by 95% for incidence between 2000 and 2013. These tumors are asymptomatic, they grow rapidly, and risk factors include immune suppression, age above 50, and chronic exposure to the sun. 43% of the cases come head and neck, 24% upper extremities, and 15% lower extremities, with initial presentation being local at 65%, and then 26% of cases have regional lymph node metastatic disease and 8% metastatic disease. We should not forget about the solid organ transplant recipients, because these patients are doing wonderful after the surgeries. So it's important to protect them for the risk for skin cancer. About 40% of solid organ transplant recipients, after 5 years of their transplant, they have 40% chance to develop actinic keratosis and Bowen's disease, and the time to develop an SCC is about 9 years. Now, it is also so crucial to remember that these patients are at highest risk to develop non-melanoma skin cancer, and as we see here, the ratio squamous cell to basal cell skin cancer is inverted, so it is 1/4 in general population, becomes 2 to 8 for those immunosuppressed patients. It's because they're receiving immunosuppressive regimens for so long. So it is so crucial to educate them and tell them they need to protect. And also the risk is increasing after the first 5 years of their surgery, and even gets much higher after the 10 years post-transplant. So for coming to therapies, for those lesions that tend to be more superficial, and they are like actinic keratosis, we use a lot of different modalities to treat individual lesions, but also the field therapy. So we approach it as a field decancerization therapy. And so we use cryotherapy, but also field therapies like photodynamic therapy. We use topical chemotherapy with 5-FU. We use also immunomodulators with imicobod and many other solutions, as well as combination of those. In photodynamic therapy, we apply a gel. This is absorbed preferentially by the lesional skin. It changes to protoporphyrin IX, which is a light-sensitive agent, and then we get the patient to be exposed to visible light, blue or red light, and this destroys all the sun-damaged areas, the superficial ones, though. And when we combine these lesions, as in this case, we do pretreatment with 5-fluorouracil, and then after a week, we do photodynamic therapy. And as a result, we see resolution of actinic keratosis and also decrease incidence of squamous cell skin cancer. As this study showed, there is decrease of flare of actinic keratosis, recurrence of actinic keratosis, actually in 1 year. And studies show that there is also better control in terms of appearance of squamous cell skin cancers in those patients. For those lesions that require surgery, we have wide excision, which can have very good clearance rates, but also we approach with the Mohs surgery or circumferential surgery. And in these cases, we have the ability to have the patient the same day in the clinic. The patient does not get any general anesthesia, is able to get back to regular activity most of the times the day after. The entire procedure is completely, mostly during the same day or maybe in a couple of days if it is with multiple specialties. And as we see here in a traditional sectioning, in pathology, we see less than 1% of the margins. So we cannot really control where exactly the tumor is in the skin. Coming deeper now with the Mohs surgery, we get horizontal samples. We process them at the same time under the microscope, and we have 3-dimensional control of the margins. So we're able to detect the tumor in histology. Then we're able to just to check it on our map. And we come with our map back to our patient, and we see where exactly there is residual tumor. So we can cut a little bit more. We have maximum sparing on normal tissue, and then we're able to move to the reconstruction with our esteemed colleagues as we have today with us together. And we do a lot of those procedures with Dr. Dimitropoulos in our department. Now, it's so important to know about protection, and one factor that can be a useful tool is sunscreens. 90% of skin aging is caused by the sun. So it is good to have SPF 30 and above and reapply every 2 hours. This is the standard of care. Studies show that SPF of 15 or higher daily can lead to 24% less skin aging than those who do not use sunscreen at all. And it's good to remember and also educate our patients that the sun damage is a cumulative concept. So about 23% of lifetime exposure occurs by the age of 18. Closing my presentation, I just want to mention that we're very thankful to collaborate with a lot of other disciplines. So we have a very active transplant clinic. Department of Surgery really has a very, very active service on that. And of course, we have close collaboration in mole mapping with Department of Surgery and plastic surgery. And of course, we collaborate quite a lot in taking care of our patients with otolaryngology and oculoplastics and many other specialties. And there is an upcoming event for free skin cancer screening on June 16th in Fosco Park. I would like to thank very much the Chicago Cancer Health and Equity Collaborative, the UI Health Cancer Center, and of course, all of you for your attendance and looking forward to our discussions. And without further ado, I think Dr. Patel and Dr. Dixon will follow with our presentations.
Thank you so much, Dr. Sukas. Okay, go ahead, Dr. Patel.
Great. Can you hear me, Melissa?
Yes, we can hear you.
Perfect. All right. I'm Dr. Patel, and I also want to welcome you for taking the time to join us today to talk about our favorite topic, which is summer and sun. And for all of us who live in Chicago, I'm sure we're really looking forward to this summer and the sun this summer as well as being out on the beach. But let's see if I can get the slide to work. All right, well, it's really important to see a dermatologist, and it's great to be able to try to prevent it, but what if you have that spot, right? That's on your skin there that you're worried about. Well, if you're afraid to see a dermatologist because you're worried that you have skin cancer and you'll be left with a hole, you need to be reassured that plastic surgeons are part of your skin cancer team. We promise you that we will not leave you with a hole. So I have about 5 minutes to convince you of this. Plastic surgeons are good at fixing holes and divots and ironing out wrinkles. And where do plastic surgeons learn how to fix holes, rips and divots? Well, the same way everyone else does, by picking up sewing skills, and for advanced plastic surgery, advanced stitching and the back stitch or the invisible stitch. So they're all very basic skills that we pick up in life, and that we just turn those into a specialty called plastic surgery. So think of plastic surgeons as good tailors. They can make the suit to fit you perfectly. Now, to be a good tailor or plastic surgeon, you have to be good at patterns. It's basically high school geometry. The pictures in a lot of our plastic surgery textbooks look a lot like geometry. It's nothing much more complicated than that. So today, I'm going to show you how easy it is to become a plastic surgeon. So where are the holes that need fixing? Now, Dr. Sukas went over those. But let's focus on the face. For example, this is basal cell cancer and squamous cell cancer, and they basically involve the face, and there's slight distribution where the basal cells are more in the nasal regions and the squamous cells are in the cheek regions. But again, from a plastic surgeon standpoint, Dr. Dixon's and my standpoint, basically the dermatologist will take care of it, and then they'll eventually send it to either one of us to fix the hole. So I'm sorry. So the fabric for plastic surgeons is not cloth, but it's skin, and we tailor the skin to fit as well as we can to fix the hole using patterns with needles and threads. And most people want to see plastic surgeons. Why? Well, because they think they're magicians and they can make the scar disappear. Now, that's our first principle. How do you hide and minimize those scars? Well, we can't really make scars disappear. We're pretty good magicians, but honestly, even magicians use invisible thread if you look at them carefully. But we can hide them in natural wrinkles, folds, and skin. So this is, of course, a before and after. And if you, and this is basically hide the scar in the forehead wrinkle. So when we can do it, the thing to notice is that we do change an adjacent structure like the eyebrow. It sort of raises up a little bit, but not so noticeable actually, but we can hide that scar well in that wrinkle there. Again, we can't make it disappear, but there's always a scar, but it's usually well hidden. Here's another before and after. Now, in this case, you can lift the skin, stretch it, and then tuck it along the junction or the border between the nose and cheek and along the lip and the cheek fold. Okay, in this case, before and after, you can hide the scar by making a parallel along the natural crease line here. It's not obvious because it parallels these creases fold. So the goal is to basically try to have it blend in as well as we can. Again, another before and after. In this case, you can lift the skin, stretch it, and then tuck it along the junction of the nose and cheek and along the lip and cheek fold. So again, you're just basically rearranging fabric like cloth. So the second principle we use is basically to preserve the shape of structures. So here's another before and after. Now you can try the simple elliptical excision that I showed you earlier, but of course that's not going to work very well because it's going to lift that nostril up. So what you do is you do a much more complex pattern to make it work. And what you're really doing is better distributing the folds like the corner of a tablecloth. As you sort of stretch that corner of the folds of the tablecloth around, you can sort of distribute the skin just like it's a tablecloth. So now, of course, this is much more complicated. It's too large of a hole by just moving the fabric around. There's just not enough cloth to rearrange it. So what do? We borrow a technique from a surgeon in India practicing about 600 years before Christ. We borrow skin from somewhere else that's a good match of fabric. And you can see in this drawing here, it's from the forehead, and sometimes you can use the cheek to do it. So, and here she is, basically using something that's an ancient technique that, of course, it's much more refined today. But again, the principles have never really changed for surgery itself. It's a very basic skill to have. Now, again, this is just another before and after. And again, it's using the ancient technique. And of course, and it goes without saying that there's nothing new under the sun. It's been, surgeons have been fixing holes for more than 2,500 years. We just get better and better with each year. And of course, preserving the ear is not so easy. You can slide the rim to close the hole. It's like using the ring on a lampshade. You can shorten the lampshade, but again, it just puckers up a little bit and shortens it. The ear is definitely smaller and the shape is not exactly preserved, but luckily you'd never see the ear, both ears at the same time, and you've got the hair to hide it. So I want to thank you for listening to me. So please don't be afraid to see your dermatologist. We're around here to help them out. And again, thanks for listening to me. We are 7 plastic surgeons, if not more, working closely together. And now I want to introduce to you our next surgeon, Dr. Tatiana Dixon. Dr. Tatiana focuses on facial plastic surgery. She's a colleague of ours, and there are plenty of surgeons here at UIC to work with our dermatologists. So if you can't prevent it, we're around. Oh, that's something else.
Thank you very much, Dr. Patel.
Sharing that? There you go. Now, Tatiana, it's up to you.
Yeah, thank you very much for that introduction. Let's see. Are you able to see the slides?
Yes, we can see them.
So my name is Tatiana Dixon, and I'm an otolaryngologist and a facial plastic surgeon. I'll be spending a few minutes talking about what types of skin cancer treatments my department performs here at the university. So otolaryngology, otherwise known as ENT, is one of many teams that work together to treat patients with skin cancer. And if patients are seen at any of these departments for skin cancers or suspicious skin lesions, we all work together so that you will receive comprehensive treatment. So there is some overlap, as you see, between the departments, but every department also has their unique strengths to offer to the patient. So there are multiple subspecialties of ENT surgeons, and many are involved in skin cancer treatment. Most commonly, though, our facial plastic surgeons will perform reconstructions of the scalp and face and neck, and our head and neck surgeons will perform some of the larger skin cancer resections. And here I've listed a couple of procedures that an ENT may be called upon to perform for the treatment of skin cancer. So wide local resections of skin cancers of the head and neck, especially for the more aggressive or advanced cancers that may have invaded beyond the skin. And we also remove the surrounding lymph nodes to contain the potential spread of disease for such cancers as squamous cell cancers and melanomas. This is also important in the staging of the disease. And then we also perform reconstructions of the head and neck defects after the cancer has been removed with plastics closures, skin grafts, local flaps, and then also flaps from other parts of the body, such as the arm or the leg. We work in close contact with the plastic surgeons, such as Dr. Patel's department, also for these larger reconstructions. When the patients come in with skin lesions, commonly the tissue that needs to be removed is far larger than the actual lesion that they see. So being prepared for these reconstructions is very important. So when performing the reconstructions, there are a few guidelines that we follow. We follow the same guidelines as the plastic surgery department. We do inform our patients that they always will have a scar, but we try to hide that scar in areas that are less inconspicuous. So at the junction of facial landmarks, such as between where the nose meets the cheek, or in the relaxed skin tension lines or wrinkles, as well as along the hairline. In addition to the placement of the scar, there are characteristics of the scar that we strive for so that scars don't draw attention to themselves. So I use this picture of a patient who came in for consultation for a scar revision as an example as the opposite of an inconspicuous scar. So you can see that the scar is raised and it's red and it's wide. It's also not in the resting skin tension lines, and it's also a long straight scar. And scars like this on the face are especially troublesome to the patient because on the face, things can't easily be hidden or covered. And if this scar were flat, thin, and matched her skin color, despite being a long scar, it wouldn't necessarily be the first thing that you see when you see the patient. So I'm going to be showing 3 examples of patients that we treated for skin cancers in our department, and each case will be progressively more advanced. So this is a woman in her 30s with a significant history of sun exposure. She presented to our clinic for an upper lip lesion. And this lesion had been present for a few months and was slowly increasing in size. It's this upper lip lesion right over here. This is a cold sore. So biopsy in clinic was consistent for basal cell cancer, and due to the location of the cancer, we sent the patient to the dermatologist for a Mohs procedure prior to reconstruction. So after the Mohs reconstruction, resection, you can see that she had about a 1.5 centimeter defect of the upper lip. And this defect also includes part of the upper red lip over here. So it was important for us to move up that red lip to restore the natural lip border. And this was performed with an advancement flap. And then we performed something called an O to T closure, hiding the incisions along the border of the red lip and then the relaxing skin tension lines. So after a few weeks of healing, as well as postoperative dermabrasion, the scar is barely noticeable. There's still a scar, as it's impossible to erase these scars completely, but they're hidden along the red lip line over here. And then as long as the scar is very thin, it can disappear into the wrinkles over here. So this is a slightly larger basal cell cancer. This is a 66-year-old patient with a cheek lesion for over 2 years. It was a basal cell cancer and it was resected with Mohs surgery. This patient was left with an 8.5 times 10 centimeter defect. The nasal sidewall cartilages were exposed, and the defect was also abutting the upper lip, the nostril over here, and the lower eyelid. And if this were just left to heal on its own, these areas would all be distorted. So we talked to the patient about a multiple step procedure. We performed a forehead flap to bring forehead skin in from the flap, forehead skin into the nose to cover these cartilages. And then a cervical facial rotation flap to bring neck skin into the cheek. Now, I think it's very important. We had a conversation with the patient that this is a multiple stage procedure, and often the patient will look worse before they look better. It takes multiple months for them to have their final result. And the patient was very kind to send some of her pictures of her healing. So over here, you see the forehead flap. She had this trunk in place for 3 weeks, and she tolerated that for 3 weeks. And then this is after her cervical facial rotation flap, and you can see that she had very extensive surgery. She was very swollen, and the scars were very visible at this point. A year after surgery, though, you can see that her scars are almost imperceptible. The area of harvest of the forehead flap is a thin white line. She has really good position of her lower lid and her nostril, as well as the upper lip. The skin match is also very good. So she's able to, if she were to point out her scars, you can certainly see them, but it is not the first thing that you notice when you see her. So our last case is a larger, more aggressive surgery. This is a man who had multiple resections of a cancer along his right jawline. He initially presented to dermatologists who performed Mohs surgery in 2019, and he had a basal cell cancer at that time. He then, a year later, noted a red nodule in that area that was resected again, and this time he had a squamous cell cancer in that area. And it appeared that that squamous cell cancer was invading into the muscle, so he had positive margins at that time. So this is a person who's had multiple primary closures at this site, and with potential residual disease in this area. So the dermatologists referred him to the otolaryngology team for further treatment. So on his preoperative workup, we noted that he had no metastases of his squamous cell cancer. However, he did have a lesion that appeared to be growing into the salivary gland of the cheek, the parotid, as well as some of the surrounding musculature. So he was taken to the operating room for a wide local excision of the area, as well as a parotidectomy and a neck dissection to remove the lymph nodes. And we originally thought maybe he would have an 8.5 times 11 centimeter defect, but as he had positive margins on frozen section, the end defect ended up being 12 by 14 centimeters. So this large defect was too deep to just cover with a skin advancement flap. And we use something called a suprascapular flap, where we take skin from the shoulder and brought it up to the neck. He did end up having an invasive squamous cell cancer going into the parotid gland, and it was going into it had spread to one of the lymph nodes in his neck. He was discussed at a multidisciplinary tumor board, and he is going to be receiving radiation therapy. So I want to thank you for inviting me to talk to you. We are the otolaryngology team here at UIC. located at the Eye and Ear Infirmary. We are happy to be part of the team to treat patients that come in with skin cancers. Thank you.
Thank you so much, Dr. Dixon and Dr. Patel and Dr. Sukas for your really great presentations. So now we would like to open for questions and answers. So feel free to type any questions you have for the experts in the chat, or you can raise your hand if you'd like, and then you can ask the question directly. So we do have one question submitted. So on a cloudy day, should people use sunscreen?
Yeah. Should I take this? I'm happy, just to share what we advise our patients on daily basis. So we recommend a moisturizer that is, friendly, and it's something that you will decide to use, because if you have something and you really don't like, you will never use. And the standard of care is to use SPF 30 and above, 30 and above, broad spectrum, that, pretty much is indicated that it's covering UVA and UVB. So we feel that even on a cloudy day, we don't get a lot of sun exposure, but there is also, penetration of the rays and also UV light through the clouds, especially UVA. So it is standard of care to use sunscreen, on daily basis. The SPF 15 gives about 93% of coverage. The SPF 30 comes to, 96%, 97%. So, it gives you a statistical significant effect, and we recommend 30 and above, just to use daily. And this is the standard of recommendation and care.
Thank you, Dr. Sukas. Another question we have submitted is, what is your consensus on DIY sunscreen? So Dr. Sukas, I don't know if you want to elaborate on this question.
Yeah, sure. Would you like to specify a little bit more the question?
So this question was submitted by an anonymous attendee.
Mm-hmm. Yeah, if it is, for something that is a little bit more natural, or something that, you have a preference, you could very well use, but we prefer to have certain products that have been tested, and also that there is indication that there is specific protection. You could use a lot of different products, but of course we really do not know what exactly is the protection that you're using. So, if you're looking for something that it is more natural, you can use like physical blockers. For example, titanium dioxide, it's something that, zinc oxide, I'm sorry, not titanium dioxide, zinc oxide is something like a physical blocker that's being used as a sunscreen. And we use even for younger kids. But mostly we really recommend, as standard of care, those sunscreens that have the indication for broad spectrum UVA, UVB coverage.
Thank you. Another question we have, does higher SPF like 50 really add that much extra protection?
Yes, comparing to 15%, as you increase the SPF, yes, you will have additional protection. But the most important point when you're using an SPF, when you're using a sunscreen, is reapplication. because if you're using a certain amount, and also you need to have a good layer of sunscreen, you know, on the skin. So if usually it's been shown that pretty much people use less than what's been indicated, like probably half of the indicated um, amount. But you know what is important is to reapply every couple of hours, because if you go outside, probably you're wiping your face or some of it is washed off, or maybe if you're out or you're swimming, so some of this sunscreen is really you know, eliminated. So I think it's important to use that um, you know, with repeated applications. If you're not outdoors, then we recommend that you use a single application in the morning. This is actually the standard that we recommend, even for winter time, because we get the question, you know, do I need sunscreen in the winter time? Yes, yeah, it is indicated to have sunscreen during the winter time as well.
Thank you. This next question, should individuals receive a skin cancer screening? And if so, at what age should this be completed?
Individual skin cancer screening is indicated, you know, as a standard of care for everyone above the age of 20, but also when, you know, we have like a general exam, like a well care examination, even for younger kids. There is examination that is, you know, happening for the skin. And if there is a lesion that is really alarming, then there is a referral. So a skin exam is standard of care. It's part of the well care for any individual. If there are any specific indications, like for example, family history of melanoma, personal history of melanoma, atypical nevi, like different moles that have been removed and have been found with certain atypical features under the microscope, then these are factors that also, you know, pretty much indicate that someone needs to check skin periodically. You know, if there are other conditions, history, you know, as we said, personal history of skin cancer, evidence of actinic keratosis, which is quite a lot of sun damage, history of immunosuppression. If you're on immunosuppressive medications, not necessarily transplant patients, but also patients that have been receiving immunosuppressive medications for a long time, then it's very important to remind them that they're at higher risk for skin cancer. And also there is recent data that shows that if you're using medications like, for example, thiazides that make you to be more photosensitive, there's data that shows that you're at higher risk for developing non-melanoma skin cancer. And so these patients need to be seen periodically by their physician.
Thank you, Dr. Sukas.
Thank you.
Next question is, how often do people need to see a dermatologist if they're worried about skin cancer?
Again, you know, the standard is to have a skin check every year and a half. And this is because you really don't want to miss something that is growing and is changing on the skin. It doesn't mean that something that's changing on the skin is necessarily a skin cancer. There are so many other growths that we get as we mature, and some of those are completely benign. So, for example, you know, we see a lot of pigmented growths on the skin, and I did not present a slide, and I apologize about that, but these are all benign seborrheic keratosis that we see on someone's maturing skin. So these are benign, but it's very difficult, you know, to make a diagnosis. And even though we use different tools, we use internet programs, I know there are a lot of very fascinating new modalities using artificial intelligence and so forth. These can provide some information to you know, to the patients, to those who really have the questions, but it's very difficult to have, you know, a firm diagnosis. So it's good to check your skin every year and a half at a dermatologist's office, or, you know, at your primary care doctor's office. However, checking your skin periodically, like self-check, is very important. And, you know, we do that on daily basis. And it's good to check, you know, every month, you know, this is just a part of self examination.
Thank you. And then the next question we have is, sunscreen is normally greasy and leaves a white film on the skin. Is there a product you can recommend that is more user-friendly?
This is a very good question. So there are so many different products out in the market. It's just so difficult to keep track of everything that is out. I agree. If it is something that is very greasy and it's feeling very heavy, and you really don't like, then likely you will not use. So it's better to pick something that there is confidence and there is willingness to use. So the sunscreen will be applied. There are a lot of different versions. Some are a little bit thicker, some others are a little bit lighter, and some others are as they're coming as sprays. A lot of young kids, a lot of teenagers are using spray sunscreen. It's more clear, it's lighter. You don't need to use a lotion. Sometimes, we have a hard time to persuade certain group of patients, to use lotions because they really don't like to use them on daily basis. So I would not go to a specific product, but I would say that there are a lot of different products and main groups like creams, some others that are more greasy, some others are clear sprays. So I would just direct through these options, and I would make sure that it really indicates that gives you a good SPF 30 and above, and also it writes broad spectrum UVA, UVB. Pretty much, all products now, they have these indications once they've been tested for those.
Thank you. Does sunscreen lose its effectiveness with age? Meaning, if I bought sunscreen last year, can I use from the same container this year?
Usually for all these topical products, the the date of expiration, it's about 1 year. So it's good to make sure that you're within the time frame as indicated from the product. Of course, if it has expired and it's been like 2 years, I think it's not a good idea to use. Probably does not give the right amount of protection. Might be that it may give you a little bit of irritation. So probably not the best idea to use if it's way beyond the expiration, as it is for all the topical products that we use.
What are your thoughts on the systemic absorption of chemical sunscreens?
There's been a lot of information that's been published on that. There is no significant evidence that the sunscreen will give you major adverse reactions. There is concern that if you're using a lot of sunscreen, you're not really making a lot of vitamin D. We recommend our patients to be active, not to stay completely out of the sun unless it is indicated. There might be that someone has a specific condition, or you're taking certain medications that do not allow you to be exposed out in the sun, or you have other comorbidities. But by using the sunscreen as indicated so far, the evidence shows that it gives you a protective effect for preventing photo damage of the skin, precancerous lesions, and skin cancers.
Thank you.
Thank you. This next question is for either Dr. Patel or Dr. Dixon. Are Mohs or resection and scar camouflage typically performed during the same procedure, or do patients frequently find themselves referred to plastics for revision?
So they typically are performed in 2 different stages. Very frequently, we actually meet the patient before the Mohs resection, so they know both surgeons beforehand. But after the Mohs resection, it's absolutely possible for the dermatologist just to cover the area with a bandage, and then the next day or the day after, the plastic surgeons can then reconstruct that area.
Thank you, Dr. Dixon. I do want to remind everyone that you're welcome to unmute yourself and ask a question if you prefer to do it that way instead of typing it into the chat. So yeah, just wanted to let you know that that is an option. We do have another question that came in the chat. Since more folks are starting to go out more due to the nicer weather, as well as increase in vaccinations after not getting much sunlight for the past year, are there certain precautions we should be taking, like maybe increasing our SPF?
Should I take this? Okay.
Yeah.
Yeah, sure. I'm gonna give you just a little bit of perspective, and of course, I think input is more than welcome. It is really important to give a gradual approach to the sun exposure, um, because when we go outside in the sun after a very long period of being indoors without any sun exposure, then there is an immediate effect of exposure, like in simple words, um, of our skin to the UV damage. And our skin has pigment cells. And our pigment cells get to be stimulated once the body, once we are exposed outside in the sun. So they get to grow. They give us, a little bit of tanning. This natural tanning, not that I mean that you have to go to a tanning salon. Um, this gives a little bit of preparation to the body, and you have a better tolerance when you really get out to be exposed to the sun. It is not unusual in areas that you don't have um, good amount of sun, for throughout the year. You have a very cloudy, dark winter, and then there is the first day that is sunny in March or April, and then everybody is out the entire weekend, and everybody is coming up with sunburns. So it's something that we very much see quite a lot. We can see it even in Chicago, Northeast. Those areas that people really are waiting for a sunny day. So this is a little bit dangerous, and it is the same thing as you've been the entire winter indoors, and then you gradually go out to be exposed. So SPF is very important, reapplication every 2 hours, and gradual approach, as we say, logical approach to sun exposure is very important. So avoid the exposure during the times that the rays are direct, like the noontime, and just prefer the outdoor activity early in the morning or later in the afternoon and still have some sun protection.
Thank you, Dr. Sukas. This next question, I know we have about 4 minutes left. So we'll try to get through the last 3 questions that we have. This next question, though, is for all 3 of the speakers. So if we can start with you, Dr. Patel, why do you do this type of work?
That's easy because I love it. Every day, it's not work, first of all. It's just something I just love getting up to doing it. I mean, as a kid, growing up, I hemmed my own pants. My parents made me hem my own pants. I love sewing. We had to repair everything in my house, and it was just natural for me to become a plastic surgeon. I was also pretty good with puzzles, as it turns out. So putting puzzles together, taking them apart, and rebuilding them. And so I really love those parts of it. And I love math and geometry and all those sorts of things. And it just all combined nicely in plastic surgery. I love working with my hands. And honestly, I am just so lucky doing what I love to do. I had another job before I did this. I used to be an electrical engineer. And I was a pretty good engineer, but I love this so much more than what I did. So I have no regret. I have kids, and I hope my kids will find something that they love as much as I do, that they get up every single morning of the day and just look forward to it. I think plastic surgery and a lot of medicine is problem solving, and nothing goes easy, challenging. Dr. Dixon, all sorts of problems. There's nothing that you can solve. It's always in a book. But we have enough principles, and we work off of principles. And so I just love what I do every single day of my life. That's it. And I just hope everybody else in this world finds something just like that. I'm glad since nobody asked me the hard question, where do I get my invisible thread from? Usually it's a magic shop off of Irving Park.
Thank you so much, Dr. Patel. Dr. Dixon, would you like to answer this question?
I have to agree with Dr. Patel. I mean, I absolutely love what I do. I love coming to work. I love interacting with the patients, working with the patients. I've also always loved working with my hands. I actually used to make all of my own clothes when I grew up. So that seems to be a common thread too. But yes, I feel incredibly privileged to have been able to follow this road, and I truly enjoy it.
Great. So it sounds like this profession, you're either a fashion designer or a surgeon. Dr. Sukas, would you like to answer?
Sure. I would like to say that, yes, I really echo the comments. And I really enjoy what I'm doing. And I figure out, I really like the comment Dr. Patel said, that you realize that no matter what you do in medicine, you're here and you try to do a better and better and better job. I love dermatology because it's a very visual specialty to begin with. And the pattern that you see, skin is here and you can see everything, and you can do all different types of research and experiments. And I really enjoyed, also a very good part of my previous research, working in photobiology and effects of light on the skin. So the skin is here, and it really tells us a lot. And the other good part, in dermatology, is that we have a lot of direct communication with the patient. So we can very well have a good participation, to their quality of life, to their thoughts, to what, bothers them, what they want to change, what they want to achieve. If the problem is serious, or maybe, it's easier to fix, or the way they perceive it. So, really enjoy that. And the wide spectrum also that we have in terms of clinical examination and recognition of the diseases, and understanding the basic science, and also having, the pathology, and having the surgery, because we do a lot of those procedures. We have the patients awake when we do these procedures. And so it is such a very close interaction in the entire spectrum of different disciplines. And one part that I so much enjoy, and I feel very fortunate also being at UI Health, is that we have this very close collaboration with other specialties. As you see, we incorporate in dermatopathology, oncology, surgery. It's a lot, like science, photobiology, basic science. It's a lot of different parts. And I really, really enjoy it. Anytime I come to work, I forget about all my other problems. So I feel very fortunate.
Thank you so much for sharing that. So we just have 2 more questions before we wrap up. So some clothing, like bicycling shirts, indicate they offer screen protection. Is this a fact?
There is some clothing that provides SPF protection. And if it is for someone to make the investment, to obtain this kind of, gear, because it is expensive. Okay. I would just get advice, first of all, see if you really need it. It might be that you have very fair skin type. You get burns very easily. You have young kids that they want to be outside. So, it's a very, very good solution. But just please make sure that you really pick the right product, so it truly has the protection that, it is indicated. And American Academy of Dermatology provides resources for those who really seek this type of products. Also, Skin Cancer Foundation. So they have this information available, like how you can obtain this specific clothing with SPF. It is important. I wouldn't say, anyone should have it. We recommend like the standard, like a hat, sunscreen, protection, logical approach. But of course, if you have additional factors like very fair skin type, red hair, blue eyes, history of melanoma in the family, problem with exposure to sun due to photosensitizing medications like, thiazides, like antihypertensive medications can do these things. So it is important to use this, and, they're very fashionable. They look great.
Thank you. And one last question before we wrap up. Does makeup that has sunscreen have the same effectiveness as a normal sunscreen?
Again, what a good question. And we get this comment a lot from our patients. And we recommend that, yes, we understand that you really enjoy using your makeup. It has some protecting factor. But, you know, our recommendation is that during daily routine, you use a layer of facial sunscreen, so it's not too heavy. We're trying to find solutions that are doable. We cannot really recommend things that cannot be applicable for the patient. So something that is light, that is made for face, it's not for the rest of the body. So it is lighter, it gives you the right protection. Let it dry, and then you can use any other product or makeup, or, you know, and even though they have sunscreen, it's better to have your regular sunscreen, because, you know, it's not really as efficient as it should be. And you're not going to use makeup everywhere, probably, you know, your neck, and I don't know, the dorsum of the hands. So it's good to have the protective layer of SPF, and then you use your other cosmetic products as indicated.
Thank you so much. Yeah, so that wraps up all the questions that we've received. And Naseema, would you like to say a few words?
Sure, thank you. Wow, this has been an extremely important discussion. I hope everyone found this conversation as informative as I did. I know a lot of information was discussed by our esteemed speakers. So this session was recorded and it will be made available to everyone on Chicago Chat YouTube channel. I would like to encourage everybody to protect your and your loved one's skin and take the precautions we heard today to assist prevent skin cancer. Also, please go ahead and get your screening completed if you have any concerns. Thank you, Dr. Sukas, Dr. Patel, and Dr. Dixon for having this timely discussion with us. It is very timely conversation, not only because May is Skin Cancer Awareness Month, but also because over the last 18 months, many of us spend the time indoor, out of the sun. And as everyone is completing their vaccination and things are opening up, it is essential that we are reminded on how to take care of our health and protect our skin as best as we can. Thank you to all our attendees and for participating and providing us with all these questions. And also thank you to UI Health Department of Dermatology, Chicago CHEC, and UI Cancer Center for organizing this event and bringing the discussion of skin cancer prevention into our community. Thank you.
Thank you so much.
Thank you.
Thank you. Thank you, everyone. Have a great rest of your week.
Thank you.
Thank you.
Many thanks. Bye-bye. Thanks, everyone.
Thank you.